So today we will do the vermiform appendix. So vermiform appendix in the human body is vestigial organ. In the herbivorous animals it is very active and its length is also more. But in the human it is vestigial organ, it no longer is remaining functional. However, it produces the cellulase enzyme which is responsible for the digestion of the vegetative material. So it is located near the ileocecal junction. This is the terminal ileum and this is the cecum. At the junction of the terminal ileum and cecum there lies the vermiform appendix. Its length is 6 to 7 centimeter, normal length is there, and the tip tapers from the base. So this is called the base of the appendix, this is called the tip. If we see the human body, the abdomen, the base of the appendix is fixed and the tip may be variable, it may be any other position, but the base is always present at the junction of a line joining the umbilicus with the anterior superior iliac spine. So at the junction of the lateral 1/3 and medial 2/3 is the right iliac fossa. So this point is called the McBurney's point. It's called the McBurney's point. And McBurney's point is very important in the appendicitis. So whenever there is appendicitis, maximum tenderness of the appendicitis is felt at the junction of the McBurney's point. So that is the clinical significance of this point. Now, this vermiform appendix is also movable because of the presence of the double fold of the peritoneum, that is called the mesoappendix. And the arterial supply of this mesoappendix runs into the appendix, runs in the mesoappendix, double fold, and it supplies the appendix and it reaches far short of the tip. So whenever there is any occlusion of the artery, this is the branch of the ileocecal artery, the terminal part of the superior mesenteric artery and into the ileocecal artery. And from this ileocecal artery arises the appendicular artery. So appendicular vessels, they are present in the mesoappendix. So whenever there is any obstruction to the arterial flow, the tip of the appendix, first of all, it goes gangrene and it ruptures of the appendix is present. And there is also a very narrow lumen is also present in the appendix, which opens into the cecum near the ileocecal junction. The various positions of the appendix, they are described according to its morphology, the position. The most common position of the appendix, this is called 6 o'clock position. Then appendix may be present paracecal in position. In this way, it is present behind the cecum. This is the embryological position at the 6 o'clock. While in the some of the individual, it reverts back and goes behind. This is called the 11 o'clock position. This is the post-cecal position. Another position of this appendix may be, this is called the 2 o'clock position. This 2 o'clock position is the dangerous position of the appendix. It may be post-ileal sometime or pre-ileal, but this is the dangerous position. It is called dangerous because whenever there is a rupture of the after appendix, there is a rupture of the appendix, and the infected material from here, it is spread to whole of the greater sac or whole of the abdominal cavity, and it causes the generalized peritonitis, which is a life-threatening condition. A patient may die because of the generalized. If it is post-ileal, then it will cause only the local peritonitis. But in the pre-ileal position, it goes to the what is called the generalized peritonitis. Another position of the cecum of the appendix is pelvic position. In the pelvic position, it is called the 4 o'clock position. So in the 4 o'clock position, it is called the pelvic position. It is comparatively safer that if the rupture occurs after appendicitis, whole of the jet of the infected material will be confined to the pelvic cavity, and the pelvic spaces, we know it increases the surface area of the peritoneum, and the drainage of the infected material is very brisk. So it is a safer position than the 4 o'clock. But in some time, what happens in the pelvic position? What happens that the right ureter also passes just near the tip of the appendix into the bladder. So sometime inflamed appendix tip may touch the ureter, and because of the touching the ureter, some irritation will be there in the lumen of the ureter, and patient may present the RBCs in the urine, and this may misdiagnose a ureteric stone rather than the appendicitis. Then there is another position maybe there, that the 12 o'clock position. This is called the paracolic position. This is called the paracolic, in which the appendix lies in 12 o'clock position, vertically upward, behind the cecum or the ascending column. So it is the 12 o'clock position maybe also. So these are some of the positions of the tip of the appendix. In all these positions, you see the base of the appendix will always remain at the McBurney's point. Only tip of the appendix is variable. So this is all about the morphology of the appendix. Now comes the applied anatomy. Applied of the appendix is the appendicitis. So appendicitis is a very dire emergency in the abdominal surgery, so it can occur at any time. The causes of the appendicitis is most common in the non-veg people is that the small piece of the fish or bone of the chicken may obstruct the opening of the appendix, and that may lead to the accumulation of the fluid in the duct of the lumen of the appendix, and the infected normal commensals, the E. coli and the botulinum, they grow rapidly inside this stagnation of the obstruction of the outflow of the fluid inside the appendix, and it may trigger the appendicitis. Or in the herbivorous people, a small flat seed of the tomato or a small seed of the guava may obstruct the opening of the appendix, and it may also trigger the appendicitis. or sometime in the chronic constipated people who are very chronically constipated, any fecalith or fecal matter, that is called the fecalith, it may obstruct the lumen of the appendicitis and it may lead to the appendicitis. So whenever a patient of the appendicitis comes, patient has to be put on the operation table and appendicectomy is the only answer. The step of the appendicectomy, that is whenever we have to remove the appendix, certain steps are taken. So first is the surgeon will do the what is called the skin incision. So skin incision given, it is also called the mini laparotomy. Small incisions can lead to the appendicectomy. So in the classical skin incision by the surgeon, it is called the gridiron incision. Gridiron incision. In the gridiron incision, we follow the fibers, the direction of the fibers of the anterior abdominal wall muscles. The skin incision is given, first of all, in the right iliac fossa, exactly at the McBurney's point, we cut the skin at 90 degrees. We know after removing the skin, below lies the external oblique muscle whose direction of fibers are the same. So we cut the external oblique aponeurosis and the muscle along the skin incision. Then in the third step, now after the external oblique comes the internal oblique. We know the direction of fibers is opposite. So we give the 90-degree incision to the external oblique. Then transverse abdominis is also transversely. So it is also given like the same incision. So one incision is previous is 90 degree to the next. So this is called the gridiron incision. After that we reach the right iliac fossa and we see the appendix inside. After cutting the peritoneal, parietal peritoneum, we reach the appendix and we see the inflamed appendix. And inflamed appendix, so we have to do the appendicectomy. So first step after skin incision now is the ligation of the vessels. Ligation of the vessel. So we ligate the appendicular vessels along with the appendix. Same incision is given. So we ligate the appendix along with the vessels. So we give the two knots, one is here and one is here. So a thread is taken and we ligate the vessels as well as the appendix together along with the mesoappendix. So two threads, two knots are applied and we cut the mesoappendix along with the appendicular vessels and also we cut the appendix. And in this way we do what is called the appendicectomy. So now appendix is removed. And this is how we do the appendicectomy. Now after the removal of the appendix, now what remains? The stump. Stump of the appendix remains there. And if this stump is not properly treated, it may lead to the volvulus of the intestine, small intestine, or it may attract the any lobe of the ileum and the jejunum. It may adhere to the raw cut end of the appendix. No doubt, a ligature is already there, knot is there, but this raw surface of the appendix, base of the appendix may invite the adhesion of the any lobe of the jejunum and ileum. That may lead to the strangulation, that may lead to the intestinal obstruction, or it may lead to the intussusception also, or it may lead to the volvulus of the gut also. So this stump has to be removed, and in order to remove this stump, a special technique is invited, that is called the purse string suture. Purse string suture. In this purse string suture is resembling the money bag of the grannies. If you see the money bag of the grannies, so this is the made of the cloth and a thread goes circumferentially around it, and the grannies they take this, and ligation of this will tighten the money bag and it will close it. So this is all the purse string. Same thing is applied here. So in the purse string suture, what we do, the area around this cecum, around this appendicular lump in the wall of the cecum, we put the purse string like stitches, and one thread is here and other thread is here. Then with the help of the forceps, we push this stump inside the cecum. While it is, one assistant is pushing this stump inside the cecum, the other is ligating these two threads, and after the operation, after this stump is buried inside and only two threads are visible on the surface. So stump has gone inside. So such maneuver is called the purse string suture, and it will prevent all the complications which may lead from the stump of the appendix post-operatively. That's all about the appendix.